This is the 9-week live IUP, empty fundus, cessational sac in the lower segment, interpreted as a short cervix with funneling membranes. So this is clearly a mistake by the radiologist. Who's at fault here, Morgan, for like letting this patient go and not actually recognizing the pathology here? Like, tell me, who do you think's at fault?
I think that the radiologist is at fault for doing this report incorrectly, but also don't think that the patient had an OBGYN consult when she went to the ED that day because it was just a live IUP and she didn't have any complaints related to the pregnancy. So I don't know that OB was consulted, but if they were, they should have also looked at the images themselves and seen that the report was incorrect.
Yeah, it's not just the report. This is where we get led down the road improperly by the radiologist, and we just have to be like we're experts as well. Like as soon as you showed that report, I'm like, oh my God, that's either a cesarean scar pregnancy or a cervical ectopic. It was one of the two, and this is just an incompetent read. But it's our job to recognize those things as well. So I'm bringing that up because this is at least the second case we've had this year, both fortunately at outside institutions where they missed the cesarean scar pregnancy. But just when you read something like this, you can't have funnel membranes in a 9-week scan. Like that makes no sense. You can't have a short cervix on a 9-week scan. Those are both second trimester diagnoses. So it's our job to look at what the radiologists are telling us, but then question it as well. And if there was no OBGYN involved in this case, fine. And then there's also a loss of information because the patient was treated at multiple sites, and I'm sure the team that was on did not see this when they started. But just really be careful when you have when the ER and the radiologists are like interpreting these things. They don't always get it right. This was the first big mistake in this case that led to the eventual adverse outcome.
All right, well, thank you, Morgan. Thank you very much for that excellent presentation. So we can just take a 60-second break, and then we will introduce our grand round speaker.
Dr. Ebert, this is Julia. I just want to make sure you can hear me.
Yes, loud and clear.
Thank you.
All right. So in just a minute, I'm going to ask Dr. Konopinski to introduce our grand round speaker. But in the meantime, some announcements about attendance. We'll be taking attendance, looking at the participants list in the WebEx at 8:10. If your name is listed clearly, then you'll get full credit with our department for attendance. The CME code will be distributed by the email system. If there's any other confusion with attendance, you can email your questions to me or Michelle or Beth. And with that, Dr. Konopinski, are you ready to introduce our speaker?
Absolutely. All right. Good morning, everyone. I'm Julia Konopinski from the Division of Maternal Fetal Medicine, and I'm very excited to present Dr. Alexis LaPietra, who will be conducting grand rounds this morning. Dr. LaPietra is an emergency medicine, pain management, and addiction medicine physician at Robert Wood Johnson Barnabas Health, where she serves as the medical director of addiction medicine for the emergency medicine and hospital service line, as well as the medical director of the Institute for Prevention and Recovery. She completed her emergency medicine residency at St. Joseph's Health in 2014, and from there went on to complete a pain management fellowship. She founded the St. Joseph's Health Alternatives to Opioid Program, or ALTO, in 2016. and her work has been highlighted in the New York Times, CNN, Fox News, NPR, and MSNBC. The ALTO program served as a national model for emergency medicine pain management reform, and in 2018 contributed to the creation of the ALTO Act, legislation signed into law by President Trump, as well as the SAMHSA ED ALT grant program, the Substance Abuse and Mental Health Services Administration's Emergency Department Alternatives to Opioid program. In 2020, she became board certified in addiction medicine, and her current work is focused on reducing the stigma and barriers to providing comprehensive substance use disorder care within all healthcare systems, as well as integrating harm reduction into medical practice. She believes all patients throughout every phase of use and recovery deserve low barrier access to medical care and continued health engagement. Please welcome her as she presents Perinatal Opioid Use Disorder Management, Pearls and Pitfalls.
Thank you very, very much, everyone, for having me. I've been with the system for 8 months, and it's been an absolute pleasure. There's so much passion and desire to treat our substance use disorder population with the most up-to-date evidence. So I appreciate the opportunity to do that with you today. We are all very comfortable addressing chronic medical disease in the pregnant patient and, of course, in your general gynecologic population. We know that they come into our offices. Sometimes we need to keep them in the hospital, but the goal is always the same: to support them in their disease process, to provide them with medications and any other supports they need. Our goals are to keep our patients healthy, keep them out of the hospital, and let them achieve all of their goals. We do this, we catch the beginning of chronic diseases by using ESPERT. It's screening, brief intervention, and referral to treatment. So this is something we do every day in our practices and in the hospital. We screen for hypertension. We screen for early onset issues with hyperglycemia. We screen with urinalysis all the time in pregnancy. And when we find that there's an abnormality, that's when we have our brief intervention with the patient. It may be a simple conversation, or it may be a referral or actual treatment you prescribe. But the screening and the brief intervention are important, and we are so used to doing this every single day. We're not even thinking about it. It's just part of our training. But this actual description, ESPERT, is an entity that we're asking for providers to use more frequently in different settings, especially when it comes to substance use disorder, because we want to catch this disease early and we want to improve outcomes. As you are, I hope, familiar, we have very high maternal mortality in the state of New Jersey. 58% of pregnancy-associated deaths are due to substance use disorder. And 87% of these deaths are stated as preventable. And in the report that the state put out, some of the issues that were identified as contributing to this high mortality are lack of care coordination, complications of the medical disease, that is substance use disorder, lack of provider knowledge, and lack of standardization policies and procedures. So we are not routinely, universally, across our healthcare system, screening, having brief intervention, or referring to treatment women who come in with substance use disorder. And we are certainly not doing it universally on women who are coming in pregnant. However, we know opioid use disorder is irrefutably a chronic medical disease. Therefore, it falls within our wheelhouse to pick this up and to address it. We know we are not experts in everything. And of course, when we're in specialties like OB-GYN, substance use disorder may not be something you are familiar with or you know how to treat. But you do have resources within this healthcare system, and there are FDA-approved medications that I believe all providers are capable of prescribing and utilizing with some education, because we do hard things every day. As I just listened to the M&M case, to me, as an emergency medicine addiction physician, very much outside my wheelhouse. But I know that when someone comes in and they need help, we know how to refer, because we want those patients to live and be safe. we have to have that same discussion about substance use disorder, because those patients are the patients that are dying. They come into our healthcare system, they come into our office, and they leave. They come in, they leave. They get admitted, they leave. I would say rarely, if at all, are they provided any medications to manage their substance use disorder, like buprenorphine, methadone, or things like a naloxone kit. And then they die. That is the trajectory of substance use disorder, and that is the trajectory of substance use disorder in our pregnant population. We see objectively with the data that they die. So when we have a gal in front of us who is suffering from substance use disorder and we let her leave our office or we discharge her from the hospital, if we have not addressed that substance use disorder, we know that that patient may not return. We have to address it when we are engaging with these people at bedside and do something to prevent the mortality. The mortality at 1 year in patients who received naloxone for a non-fatal overdose is around 7.5%. And this has not changed. We've been looking at this for over a decade. The mortality is still the same at 1 year in folks who receive naloxone. And of those who receive naloxone, 8.3% of them are dead in 72 hours. And a lot of these folks are coming into our hospitals. This mortality is really unacceptable when it comes to other chronic medical diseases. If you had someone come in and you were looking at them and knew they had an 8% mortality, you would never, ever let them leave your department. You would keep them and you would do whatever you needed to do to provide them care. For substance use disorder, for opioid use disorder specifically, medications for OUD, medications for opioid use disorder, which are defined for this discussion as buprenorphine or Suboxone, Subutex, and methadone. Starting folks on those medications bring that massive mortality almost down to that of the general population. So we take a huge mortality population, we initiate medications for opioid use disorder, and we bring that mortality way, way down. It is an incredible mortality reduction that is not paralleled in really a lot of the interventions we do every single day. Small mortality reduction is great. Massive mortality reduction, rare. It's rare that we see that and that we can play a role in that. This slide represents some of the evidence around the things we do every single day. So quality evidence-based initiatives, and we're using number needed to treat. So when we do these big meta-analyses, randomized control studies, we're looking, do these interventions actually change care? When we have patients with stroke, everybody gets antiplatelets, because of 40 people who get antiplatelets, 1 will have a better outcome. For preeclampsia, for 19 folks who get aspirin, 1 will have a better outcome. And for magnesium, for seizure and abruption, 100 patients get it for 1 benefit. So we do this for everyone because that 1 is a huge win. So everyone gets that. The evidence supports that. For buprenorphine, which is abbreviated BUP here, for buprenorphine, in someone who has opioid use disorder, if you give it to 2 people, 1 of them is going to stay in treatment, is going to follow up. 1. So we give 100 patients magnesium for 1. This is 2 humans. 1 is going to have a better outcome. So that number needed to treat, if that doesn't jar you a little bit, I'm not sure what will, because we can really, really see the massive impact. And this is the stuff we do every single day, all those other NNTs. But this is something we absolutely have to integrate. So of course, no one is coming into work and saying, I'm not treating addiction today. We know absolutely that is not the case. But we know that there is a massive stigma because historically this disease was very, very misunderstood. It was believed to be a moral failing and a disgrace. Of course, we know that's not true, but that traditional thinking has carried into 2024, that we know. We're a little bit ignorant, and maybe that's not the best word, but we really don't know. We weren't taught this information in training. We know that if you've been out of training for more than 5 years, you probably did not hear the words buprenorphine. You were probably running away from anyone on methadone, or at least, methadone patients we weren't as comfortable treating. There's a ton of myths and misconceptions about specifically buprenorphine because of that X waiver that we have. That is gone, by the way. Anyone with a DEA can give buprenorphine or methadone in the hospital, and anybody with a DEA can prescribe buprenorphine. So that waiver only created more mystery and more barriers. And also, I think we feel that the well-established referrals to endocrinology or MFM or whoever we're always referring to, that is easy for us, but we don't have a standardized referral pattern. Therefore, we think, I'd rather not know. I don't know what to do with this person if I find out. And that's something, again, we have to change. So for a long time, we did not know how to do better. We were all doing the best we could with substance use disorder. But today on, we are going to know better. Everyone on this call is going to know better. And that means we must do better. And it's really unacceptable to not be screening, intervening, and treating. So to briefly explain the neurobiology, which convinced me as a physician that this is a disease, this is medical, and we need to get on this. The neurobiology is just a little bit helpful to understand. So a lot of folks, when they receive opioids, the opioid binds to the mu receptor in the brain like we know it should. And the typical cascade is that of significant euphoria. A lot of dopamine gets released. And this is what we want because that helps to block pain. So the opioid is doing its job, it's binding to the receptor, and it's causing a spike in dopamine. We want that. Now, genetically, there are folks who have an opioid and they become delirious and they vomit and they feel terrible. So in the genetic lottery, their mu receptor is functioning a little bit abnormal. But for the majority of the population who has an opioid, they have immense euphoria. So folks who try opioids, who are using them either recreationally potentially or a prescription, they may feel incredible. And depending on what's going on with their genetics and with their life experiences and with trauma, that feeling may really just fill a hole, may feel so good for them at that time. They continue to use. And again, multifactorial, genetics, environment. They suddenly find it's not fun anymore. So in someone with opioid use disorder, in the throes of addiction, if you ask them, are you having fun? They will tell you they are not having fun. By definition, when you have opioid use disorder, there is harm. There is harm you continue to use despite that harm. So it is no longer dopamine driven. It is no longer fun. People are no longer getting high. They are really just trying to not go into withdrawal, and they are also compulsively using. A lot of the time, they don't know why they can't stop. They still do it. And in the addiction research world, we didn't know for a long time why folks couldn't stop. If it's dopamine driven, then that's good. Dopamine is a pleasure hormone, but that's what it was not what it was. We came to find out that after repeated exposure to potent substances like opioids, a transcription factor gets turned on in your brain that otherwise is not turned on. And it's called delta phosphate splice variant. And this transcription factor is responsible for the hijacking of your brain. And this is its job. It takes all the pathways of behavior and drive that existed, and it completely revamps them. It changes the entire architecture of the brain, and no longer am I, Alexis, going about my routine and my behaviors, which have been cultivated over decades. I am paving brand new neurobiologic pathways, all geared towards the procurement of that substance. It is compulsive use, despite harm. This, now with delta phosphate, is driven via glutamate, no longer dopaminergic. So to explain a little bit about what those pathways are, we're going to use the horse, the rider of the horse, and the brakes or the reins to reel in that horse. In a healthy brain, we have a limbic system that is all pleasure. So that's what helped us survive for millions of years. We eat, we have our tribe, and we have sex to procreate. Those are very pleasurable activities because that's what keeps our species alive. That area of our brain over time has gotten a little bit smaller. Now we do other things besides eat, have sex, and only hang out with our community. We have executive functioning centers like our prefrontal cortex, which help us negotiate these cravings or these ideas or really our everyday behavior. Then with the motor cortex, the anterior cingulate gyrus really will put the brakes on an action. So I want to stand up, I want to get more coffee, someone's lecturing, that would be unprofessional. I'm not going to do that. So that thought does not lead to a motor function of standing up. This is what happens in our brain every single day. And we do it kind of mindlessly. You know, we get in our car, we turn on the car, we start driving. You know, it's mindless. We don't even think about what we're doing when we get in our car. But if you remember when you first got in a car, when you were younger, everything was scary, everything was new. You didn't have these behavior patterns. So we have to remember this stuff is well established over time, and it really happens millions of times a day. In patients who have opioid use or substance use disorder, delta phosphate works really hard to get the limbic system more input and to have the limbic system have a much stronger connection to motor activity. So it bypasses a lot of prefrontal cortex interaction. It bypasses anterior cingulate gyrus or our brakes, and it has a lot of input from limbic system, this is what I want to do right now, to motor function. And that's where the compulsivity goes. I want to do this. There's no maybe I should, maybe I shouldn't, I don't know, let me negotiate, let me go back and forth. It's just go, go, go. So there's an idea that you want to use, and that's it. And there's these trenches that form, and you're kind of marching along in this trench, and you're not able to sway from that behavior. And this is the compulsive disease from a neurobiologic point of view of SUD. So if we think about the aberrant pathways and kind of going off script, this happens to healthy brains all the time. So if we can be empathetic or imagine what it would be like to be a substance use disorder patient, it would mean we went off script when we got really mad. We were so emotional. We could not handle the situation. And then we do something. We yell, we act, we scream, we're violent, whatever it is. We walk off the job. That is an aberrant pathway for us. That's not our well-oiled executive pathway. And when we do that, we kind of fall off the horse and we let the horse drag us. This is what happens to substance use disorder patients every day. They're off that horse. They don't have executive functioning connected. But for a healthy brain, often, very quickly, we realize what we did and we stand up and we often have to apologize to someone. And we acted out of anger. I wasn't in my right mind. I was so upset I couldn't think straight. So when that happens, we get back on our horse. We pull our reins and we continue to trot along. But for a substance use disorder patient, because of the disconnect of the prefrontal cortex and the anterior cingulate gyrus, they are off the horse. They are galloping along, just hanging on, and they really don't have the ability to get back on and to reclaim the way that they'd like to be acting. Another thing that happens with opioid use disorder specifically is it takes over the fight or flight button, which is in the locus coeruleus in our brainstem. So opioids inactivate our fight or flight button, which of course we know is linked to survival. So when we have opioids in our brain, the fight or flight is completely inactivated. It doesn't matter if the house is burning down. It doesn't matter if our children are screaming. It doesn't matter that we're going to get fired from our job. We have no fight or flight. When the opioids start to metabolize off the receptors in the locus coeruleus, then the fight or flight button goes crazy. The fight or flight button is in full rage. Anything and everything we have to do to get the opioid back on the receptor, that is priority number one. We would walk into traffic. We would leave our child. We would be in a very unsafe situation because your brain is saying, you will not survive until you get opioid back on your receptor. And this is brainstem. And when we see folks in opioid withdrawal, you see the sympathomimetic surge, the tachycardia, the sweating, the massive restlessness. This is not because they want to be agitated. This is because the locus ceruleus is pushing out signals and adrenaline is surging that they're going to die. They have to get this substance. And the last area that's really affected is the medial orbital frontal cortex. That's our social connection. So that is where we have dopamine spikes. Remember survival? That's where our dopamine spikes for tribe and community. So a long, long time ago, we could not survive by ourselves out in the wilderness with the saber-toothed tigers. We had to have our community, our tribe, our people. So when we're around whoever we love, our dopamine spikes, and then we keep seeing those people. When it comes to substance use disorder, that area is shut off. And now the connections that form, delta phosphate is forming these new pathways where the only excitement we have related to connection comes from being with the drug. And that is why we see folks isolated. They don't go home for holidays. They don't want to see their mom, their partner, their loved one, their children, their pet. Because no longer are they getting that positive reinforcement from seeing those folks. The positive reinforcement is now only with the substance. So having said all that, when we look at someone who is suffering from substance use disorder and we say to them, and we've been saying this for hundreds of years, just stop using, muscle through it. That is an ignorant statement and completely unrealistic. They have a neurobiological medical disease. They can make a full recovery, no question about it, but they cannot make it quickly and without help. There is immense suffering that goes on in active use, immense shame that goes on. Shame is the feeling I am bad. Guilt is I did something bad. Guilt you can apologize for. Shame, no apology can be made. The only antidote for shame is empathy, for a human to say, I get it. You are not bad. So shame really needs to be combated with us as healthcare providers showing empathy towards our patient population. When we think about the way we treat other suffering, other diseases that cause suffering, let's talk about pain. If you have a patient who had a femur fracture, regardless of the specialty you practice, if someone said, I have a femur fracture, I fell off my bike, the doctor said I'm going to heal, but every time I walk, it's painful. And we said, well, you're going to heal, so just, I don't know, do the best you can to not ride your bike. Well, I'd like to be a normal person again. I'd like to be able to walk around and run, be with my family. You say, well, just say no to the bike. Just don't get back on the bike. No, but I'm suffering even without the bike. Well, I don't know what to tell you. You'll heal. And you'll stop suffering when you heal. But that's 6 to 8 weeks away. So what do we do for people who are suffering from medical issues while their body is healing? We give them crutches. Now, physically, for a fracture, or metaphorically and other supports, we give them something so they're able to move around and to treat and to be a human again. And this is what medications for opioid use disorder are. The brain will heal. We know that from traumatic brain injury, from stroke, and from all the millions of people who are in recovery, who are in long-term recovery. Their brains have healed, but we provide them no support. We get 5-day detox is physiologic dependence, not the disease. So we treat these symptoms, we're not treating the actual disease. We also, when we talk about maternal health, we really have to be church. And that is not it's not religious per se, what I'm saying. It is a safe haven. So women who have substance use disorder, they have immense shame. They come to us reluctantly for help. And when they come to us for help, if we are exuding shame and negative behavior towards them, they're gonna leave. We don't need in our negative interactions with them, that's not going to push them to stop using or to get healthy. We are just adding to their shame. We are adding to their burden when we are stigmatizing. So when someone is using and pregnant, they already are beating themselves up every single day. They are already full of incredible shame. They don't need it from you. They don't need it from the healthcare staff. What they need from the healthcare staff is safety, empathy, kindness, and a no judgment environment. And that's what I mean by church. Come as you are. No matter what, we'll accept you into our healthcare setting and we will help you. You are suffering. So when you give somebody the eye, or even things you're not aware of you're doing, but there's this feeling towards substance use disorder patients, there is no benefit there. There is only patient walking out with a massive mortality in New Jersey. So women, stay away from us. Women who have substance use disorder and are pregnant, literally stay away from us, because traditionally we have been mean. Traditionally we are stigmatizing. We're not nice. You know who's nice to these people? Is their drug dealer. They're very nice and very accommodating. We are not. So the conversation has to change. When you see somebody who comes in and they either you're screening them, you see they have substance use disorder, they tell you they have substance use disorder, we have to say, I want to address everything going on with you, all of your medical issues. I want to make sure you're safe, and I want to make sure your baby's safe. If they're staying in the hospital, I believe that there's a possibility you're going to go through withdrawal based on the medical issues that you have. So tell me up front how I can help you with potential withdrawal, because we can give you medications. We don't want you to suffer. We don't want baby to suffer. And then we have to remember that when we're having these interactions with the patient, it has to be an empathetic discussion. I mean, if we're not willing to treat withdrawal, which is a medical issue, then of course patients are going to bring drugs into the hospital. They know, based on prior experience, if I have to stay in the hospital, no one's going to treat me when I start to go into withdrawal. I'm vomiting, I have diarrhea, and I feel like I could rip out of my skin. So I'm going to bring drugs with me so I can feel normal while I'm in the hospital. So that has to change. We would never say to somebody, your blood sugar is going to get really high while you're in the hospital. I'm not really comfortable giving you your insulin, so do the best you can to only eat broccoli. We would never say that. We would say, your blood sugar is going to get high. You have diabetes. I therefore will give you insulin while you're in my care to avoid any bad outcomes, to help you be stable and to help you be healthy. Not a question. So how do we do this? We treat with buprenorphine and methadone. We do not use naltrexone or Vivitrol. These are the two medications we're going to use. The benefits of medications for OUD in pregnancy are very clear, that there's improved adherence to prenatal care, and we also know people engage in more recovery support. It reduces the risk of obstetrical complications. Abstinence-based models of care that just go to detox and then just say no, and they're not using any substances to help, any medications to help, they have a 90% failure rate. And when you stop using illicit fentanyl in New Jersey right now, and there's a period of time where your body loses its tolerance, and then you're having a bad day, like we all have, and I mean, maybe you have a kid, which is rough, you relapse, you have a very high chance you're going to die, because the fentanyl is extremely potent. So abstinence-based models, just letting the patient heal naturally without support of buprenorphine or methadone, have a 90% failure rate and a very high mortality. And we know that when folks get on MOUD, that helps DCPNP and when they get involved. And we, again, want to support our patients medically. So when someone has substance use disorder, a clinician will do levels of care. So the American Society for Addiction Medicine, sorry, I don't know why I have American academic, that's wrong. American Society of Addiction Medicine levels of care show that either the patient needs to go in the hospital for their substance use disorder, or maybe they could go outpatient. But I want you to know right now, if someone has substance use disorder and our current levels of care, the lowest level of care they can get for their addiction is to be enrolled in an outpatient treatment program, and that's at a behavioral health center. It's mandatory that they go for counseling just to get their buprenorphine. They cannot get buprenorphine unless they go to counseling, and we all need counseling. Anybody who has a brain, we all need counseling. But it is a sin to say that this very high mortality group cannot just get medications for their disease, that they need to have mandatory counseling. And some people can't make it to counseling. Some people are working or they have children and they just want to take their medication. We don't make people who have a heart attack go to the gym to get their Norvasc or lisinopril. We don't make people who are on metformin go to a nutritionist and show us that they're going to the nutritionist 9 hours a week, because otherwise we're not going to give them their metformin. Never, ever would we do that. But we take this medical disease and we say, you can't get medications unless you go to all this counseling, and that's it. So that's why mortality is so high. We offer no low barrier interaction, like we do offer low barrier interactions for every other medical problem we treat in this country. So we really need to have low barrier care. What that means is the doctors people are seeing should be prescribing that medication, not only behavioral health. Everyone needs to ultimately end up in counseling, but let's at least get them on meds. Let's at least get them in our office. Let's at least start the process of healing, and we can give the medications, because we're not mandating any counseling. We're doctors and providers, and we want to treat. So the medications we can use are Subutex, Suboxone, and then Sublocade is an injectable long-acting every 30 days. We're not going to talk about that. Subutex is the mono product of buprenorphine. So just straight buprenorphine in a tablet only, that's Subutex. There's also Suboxone, which is buprenorphine and naloxone together. That comes in a tab, that comes in a film. The films are much, much easier to utilize. They dissolve really quickly. The tablets are really, really chunky. So a lot of folks prefer the film. Some folks prefer the tablet. We shouldn't care what they prefer. ACOG says they can take buprenorphine naloxone, or they can take just monoproduct buprenorphine. But if we want to get a film that dissolves in 5 minutes instead of 15 to 20 minutes, then we have to use the combination. So buprenorphine naloxone is the only way to get a film. So we talk to the patient about tablet versus film. The naloxone doesn't matter. It does not get absorbed sublingually. The naloxone is added as a deterrent, so people don't inject it, which they're not anyway. So we want to really kind of more so lean on the film, but of course this is a patient provider discussion. Sublocade we can get to another time. So buprenorphine. Buprenorphine is a beautiful, amazing molecule, but it has some things that are a little annoying. So one thing that's really beneficial is its partial agonism. Unlike fentanyl, oxycodone, and methadone that activate 100%, buprenorphine is a partial agonist and it only activates the receptor 50%, which makes it so much safer than any other opioid because you cannot get respiratory depression. No matter how much buprenorphine you give, and there have been studies that look up to 96 milligrams in one dose, you can only drop the respiratory rate 50%. And in a healthy individual, that's not going to kill them. So no dose-dependent apnea is a beautiful safety function of buprenorphine. The other amazing quality is its high affinity. It does not come off the mu-opioid receptor. So once it's in the brain, it binds, which means if fentanyl or oxycodone or methadone come floating around, it's not getting bumped off. You are not going to overdose. Now, one issue with that high affinity is that it can precipitate overdose. It can precipitate withdrawal. So when it comes into your brain, because it has such a high affinity, it will knock off all the other opioid receptors, all the other opioid molecules, but then it only binds that 50%. So the brain goes from 100% activation, bupe comes in and knocks everything off, and then it's only at 50% activation. So we're going to talk about what that causes. The other benefit is it has slow activation and slow elimination, which means you don't get this spike in dopamine. And if someone who's opioid tolerant, their brain sees opioids every day, they will not get euphoric. So the benefits of high affinity partial agonism are clear. We just talked about them. No overdose, stays on the receptor, no apnea. But when we use bupe in a brain that has full agonist in it, we're going to cause a precipitated withdrawal unless we use it properly. So the Niagara Falls over here is someone who's using illicit fentanyl or oxycodone every day. Opioids every day means a lot of activation. You then add bupe to the mix when all those opioids are there. You turn Niagara Falls into a trickle. And that's buprenorphine precipitated withdrawal. And that's a very feared complication in the community, in people who have substance use disorder. They know about it. It's terrible. So they want to avoid that. So all the benefit of buprenorphine, this is the one issue, is how do we start it? We can't just start it whenever we want. In someone who is less than 20 weeks, of gestation are what I'll talk about now, the initiation of buprenorphine is the same. So less than 20 weeks, it's going to be as if they're not pregnant. Over 20 weeks, however, that is when we need to bring folks into the hospital. They are very high risk. When we do our bup initiation, we want to monitor them. We know they have a high mortality. We really need to make sure they get on the medication, and we really need to make sure we plug them into resources. So the traditional approach either could be outpatient, a home induction, or if we're bringing them into the hospital, we're going to use the clinical opioid withdrawal scale to get an idea of what's going on in the brain. What opioids are left over? Are their receptors ready for the buprenorphine? We want to avoid that withdrawal. So it's a 0 to 48 scale. We want to do it with the patient, and we also want to keep in mind that because of the potency of illicit fentanyl in 2024, we really need to make sure folks have not used for about 24 or 48 hours. If you do this COWS at 12 hours since last use, you can get a pretty good COWS from all the subjective issues. They're not going to be ready for buprenorphine. We also have to keep in mind time since last used. So we simply ask, can you tell me when you last used? In an empathetic way. I don't care when you last used, but I just want to help you and know when I can start you on the medication. And while we're waiting, so if they come in, 10 hours since last use, we know we're going to be waiting a little while. We want them to wait, but be comfortable while the opioid is metabolizing off the receptors. So in pregnancy, we have these medications that we can use for all of the symptoms that they're feeling. COWS over 8 or greater is really kind of the mark, keeping in mind 24 hours since last use with objective signs of withdrawal. So they have to have at least one objective sign, 24 hours since last use, and the COWS of 8 or higher. And then we dose with bup. Now the dose varies, and there's a lot of discussion right now in the addiction world about the right dose. Fentanyl is very, very, very potent. Some folks are injecting up to 3 milligrams multiple times a day. That's fentanyl. So we give 100 micrograms, they're injecting 3 milligrams multiple times a day. So starting at 8 is okay. I advocate even starting higher at 16. We're not going to overdose the patient. We want to saturate all their receptors with buprenorphine and get them feeling well. So starting dose can be from anywhere from 8 to 16. We then need to reevaluate and see, did the bup bind to enough receptors? Is that COWS score coming down? We need to make sure our patient is feeling well. If the COWS is better, but still a little bit high, then we just give more. Again, we just want to saturate receptors. When we give insulin, we don't really care what the blood sugar is or if we have to give more. We just want to make sure they're getting better. And when the patient says they're feeling better, we see that the COWS is improved, we're done with our initiation. The recommended max for the initiation phase is 32 milligrams because we don't believe there's many receptors left after you give 32 milligrams. But if a patient sometimes they spit it out or they swallow it or they start talking and it just doesn't get absorbed properly. If you need to give another dose, that's fine. Again, you can't hurt them with buprenorphine. You can't overdose them with buprenorphine. If you give bup and you come back and the COWS is, these slides are really all just to say, if the COWS is moving in the right direction, keep going with your bup. But if you feel like you're getting a little bit better, but you didn't make as much improvement as you like, that's a time where we have to just ask, did you swallow it? Did you chew it? And then we also have to see, are there other substances involved? So when you start doing this with a dose of 8 to 16 or bup, the patient's going to be a lot better. But as you see patients maybe aren't getting better in the way you expect, those additional questions have to come in about benzodiazepine use, about alcohol use, crack cocaine use, and also just taking a look medically to make sure there's nothing else going on that's contributing to some of these symptoms. The one scenario that I talked about, buprenorphine precipitated withdrawal, this is the goal is to avoid this, but if it happens, it's treatable. This scenario is going to look like this. They have a COWS, you're feeling like they can get it, you give your dose, you come back in or the nurse calls you and they're worse. So they're not a little better. It's not a question. They're worse. That means you have precipitated withdrawal. And, we have to deal with this and we can treat it. The treatment is just more bup. And it sounds a little counterintuitive and the patient's going to look at you a little funny, but you have to explain, we gave a medication that partially covers the receptor. We didn't give enough. We just have to now flood the brain with as much buprenorphine as we can because it's only binding a little bit. Therefore, we need to get it on as many receptors as we can to quiet the brain down. And for that, we have a max of 32. It is self-limiting. Buprenorphine precipitated withdrawal will be better in around 24 hours. So we need to coach the patient, let them know we gave them all the bup we can right now. We're going to give them that symptomatic treatment that I spoke about earlier while we were waiting for the cows. It's the same symptomatic treatment if we precipitate withdrawal. Encourage them, support them. When this happens, it's a little bit traumatizing, but we don't want patients to then not use the bup because it's really our safest option for them. Less neonatal opioid withdrawal and just easier because it can be prescribed as opposed to methadone where they have to go to the treatment program. So we want to encourage them and we want to make sure that we get through this phase. When someone has been successfully initiated on buprenorphine, then we make sure we give them a prescription. And we can also do this in the office by giving them a script for home. Of course, they need to have education, they need to have support, but we need to be providing this medication as a prescription, and all of us can do that if we have a DEA license. This is a little bit more complicated, and this is probably for another time, but if we are trying to avoid withdrawal, we are not looking to do an abstinence-based withdrawal. So this is sometimes folks that are on methadone, maybe for chronic pain or OUD, they want to get off methadone onto bup. We have to do something called a micro-dosing protocol, where we use just a little bit of bup, we keep them on their full methadone, and we kind of move the seesaw from all methadone to all bup. And I think this is probably, again, for another time. The last thing I want to talk about is xylazine. You may see it, you may not have seen it yet, but xylazine is an adulterant that is in our illicit opioid supply. It does not cause respiratory depression. It causes prolonged sedation. We see very disturbing wounds that are not related to the injection site. So even people who are snorting xylazine fentanyl, they have wounds in distal areas. So it's not related specifically to injection, but it has a different withdrawal. So folks need to get naloxone when they're down. That reverses the fentanyl issue, but they may still be quite sedated even though they're breathing well. That's probably xylazine. And as they start to wake up, they're going to have withdrawal from their opioid. They're going to have withdrawal from xylazine. Xylazine's not responsive to buprenorphine because it's not an opioid. So the withdrawal dosing, this is our System Tackling Addiction Task Force algorithm. It's a guideline for how to treat the symptoms of xylazine withdrawal while you're also giving buprenorphine to treat the opioid withdrawal. And to briefly touch on methadone, if patients say, I have a bup allergy and I can't be on bup, please ask them why. What's your allergy? You will often find it is vomiting or agitation, or it just made me feel a little crazy. That's not an allergy. They were precipitated. That was bup precipitated withdrawal. So you can explain to them, you probably took it too soon, or you know, whatever happened, it was not the right way. Let's give it another try using our cows, using time since last use, and using objective signs of withdrawal. If they adamantly do not want buprenorphine, then we have to give methadone. Anybody can start methadone when a patient is in the hospital. The dosing is a max of 40 milligrams on that first day. You can give 30, and then in 4 hours, if they still have symptoms, which they probably will, you can give another 10. Then you keep them on that 40 for 2 days. Every 48 hours, you can increase by 10. So they're on 40, 40, 50, 50, 60, 60. And you can escalate up. The recommended stop, I believe, for acute care patients is around 100 milligrams. After that, you know, they should have no more symptoms, and we really would have the opioid treatment program do more titration. But please don't avoid methadone in a patient who's actively withdrawing because you think you can't give it. You can. And then we will plug them in to an opioid treatment program for them to continue their methadone. When they come in and they deliver, don't stop their methadone. Don't bring their methadone back down. We don't need to do it that quickly. Neonatal opioid withdrawal syndrome. Babies who are exposed to buprenorphine have significantly less withdrawal than babies that are exposed to methadone. And that's another reason why we promote buprenorphine. In patients who are on methadone or bup, we encourage breastfeeding, eat, sleep, console, rooming in, skin to skin, and swaddling. When folks come in on buprenorphine or methadone, do not touch their dose. If they have pain issues, we give our alternatives, and then we give higher dose opioids because they're an opioid tolerant patient. Just like if someone came in on OxyContin or MS Contin every day and had a C-section, if they needed opioids, we'd have to give them higher doses because their brain sees opioids every day. That's the same thing with an MOUD patient. So in summary, it is absolutely our job to screen, intervene, and refer these patients to treatment. It's our job no matter what, but I would argue in the state of New Jersey, it is ethically imperative because these women are dying in New Jersey. So we have to have empathy, kindness. We have to be church. When they come to us, there is no shame and there is no stigma because anything you're dishing out, they have been dishing out to themselves 100-fold. So your criticism is not going to get them healthy. Your kindness is going to get them healthy. We have to initiate buprenorphine in the hospital and be comfortable doing this as part of our routine care. We do way harder things like postpartum hemorrhage management, way harder. We just have to get used to doing this. It's not hard. We have to build our own rut of behavior and doing this. Methadone can be started. The max daily dose is 40. Please do not stop methadone and do not stop bup if folks come in. We don't want to take them off their medication. And then I want to give a shout out to the Institute for Prevention and Recovery that staffs all 12 hospitals and at New Brunswick has a special maternal health grant. This is dedicated peer support. So this exists in all of our hospitals, 24 hours a day, 7 days a week. You can consult peer recovery to come to bedside. At New Brunswick, with the maternal health grant, you have doula certified peers who are in long-term recovery, and they're not to serve specifically as doulas, but that doula training helps them provide a better environment for the pregnant patient. They can come to the hospital, and they're also going out into the community, meeting folks at appointments, organizing care, getting formula, diapers. This program is incredible. And we have two of the specialists here. We have Angela Chiquino, who is our manager, and we have Katie Mayer, who is the supervisor. They run this program, and we are so, so lucky to have it. We are trying to embed them more in Epic and do automatic triggers so that they just show up and you don't even have to trigger them. So more to come on that. And of course, there'll be more order sets. And everyone needs education, nursing education, provider education. So this is the beginning of a long journey for our healthcare system, but it's no longer whether or not we want to do it. We're doing it now. So let's go ahead and make an effort to get comfortable because of course we really need to decrease the mortality. And that's all I have.
Thank you, doctor. Thank you so much for that excellent talk. Are there any questions?
Hi, Dr. Ebert. This is and thank you so much, Dr. LaPietra, for your talk. This is Dr. Sweat Patrick. I'm one of the maternal fetal medicine doctors here, and we work really closely with the maternal health peer recovery program, and I can attest to how amazing they are. I guess I have a question and a comment. Your talk is super timely. I actually just tried to help take care of a patient a couple weeks ago who came into the ER. Had a precipitated withdrawal from buprenorphine, ended up getting IV methadone. This was all before OB or MFM was involved in her care. And ultimately, the end result was we never really got her withdrawal symptoms under control. She left AMA, and we had a real missed opportunity to, be church for that patient who was 27 weeks pregnant, who had no prenatal care. And I still stress about her now, and I hope she's okay. So I guess I'm wondering, from an ER to OB kind of standpoint, are there protocols going in place, or it sounds like this entire event, especially with everything you just educated us about, is really unavoidable and preventable. And how can we do better, both from an emergency room and from an OB standpoint?
Thank you so much for sharing. And I hear you. It's painful when we know those missed opportunities exist. And with the disease of addiction, you know, we know that we really need to be gentle with the patients. And we know, I mean, you've probably seen even post-delivery, they're barely recovered and they can AMA. So, you know, it's a tough population. And if they're in front of us, we do have to hold on as tight as we can. Number one, in this new role that I have, I would like to review any cases and be able to provide dedicated education to fill learning gaps that we already know exist. So number one, I would love to, if you're comfortable sharing the case, that I can bring it back to the ED, and it's really just all education, not punitive, nobody's getting yelled at, but just we're not doing this routinely, and every chance we have to improve the quality, we have to. And when I get specific cases, it really helps hone in and give that dedicated education to staff. So I would ask that you send the case, and then, you know, my first stop when I got here 8 months ago was emergency medicine. And it's been 8 months, and we're doing a lot better. But of course, like any culture change, it takes a long time. So the repeated education, the highlighting of cases, ideally, the patient would have been managed with 32 of bupe and then all other symptomatic care. And even if we needed to go down and be using benzodiazepines or other intravenous medications, we can avoid the handcuffs that are methadone, and we can also provide care in which the patient feels well enough to stay. So it's a learning opportunity for all of us. And my email was shared here, and of course is easy to find. So any cases or questions, escalate them to me, and we can discuss education on how we can improve our care.
Awesome, thank you. I will happily forward you the information for that case.
I see that Dr. DiCenzo has her hand up.
Hi, I'm one of the residents. This is probably repetitive because I was going to comment on, I was with Dr. Patrick for that same patient. I was going to say if we could loop like all of the people into the conversation, because I think a lot of the time we kind of maybe erroneously rely upon our psych colleagues to help us in managing these patients, but often it can be like difficult to get in touch with them in a timely manner, especially if stuff is happening in the middle of the night. And then also, interestingly, a lot of pushback also seems to come from the pharmacy in terms of like who's able to order it, if it's OB that's ordering, if it's psych that's ordering like the methadone, and like verifying the doses and getting the doses to the patient in a timely manner. So I think I definitely would love for you to kind of encompass all of those people in that conversation. That would be amazing.
Thank you for sharing. Pharmacy, please. So it's everyone on the team, as you're stating, Dr. DiCenzo. It's pharmacy who's on board, top down on board, and we know that, you know, at the top down takes time to get down. You know, this dissemination of information is so difficult in even a single site, let alone a system. But our corporate pharmacy team is 100% on board and has been pushing things as fast as I'm throwing them out there, and the team is asking them to act. They are acting. So again, the one-off cases, we need to provide dedicated education. And so you're empowered. We do have an opioid policy that's coming out about methadone and bupe, who can do it. It's not who can and who cannot. Everyone can. No one needs psychiatry to treat substance use disorder. They may need psychiatric care for mental health, but the disease of substance use disorder is medical, and we treat it. So anybody with a DEA is ordering buprenorphine or methadone. It does have that max of 30 and then the 10 after. So if you order 40, maybe you'll get pushback. It needs to be 30. Fine. You'll order the 10 4 hours later. But if you have issues with that, I need an email. I need to know, I need to know in real time who was involved in that patient and what are the delays, because all of us just need education that we never got. And we will do this in a, sympathetic way, but we need to get everyone on board. I hear you.
All right, are there any other questions? All right, well, again, thank you so much for this excellent talk.
You're very welcome. Thanks for the opportunity.
Thank you. All right, well, we'll end a little bit early today. Thank you, everyone, for your attention. I hope everyone has a safe and successful day.
Thank you.